Our lecture today is about musculoskeletal tumors. We will go first through an introduction to bone tumors, then we will discuss benign and malignant tumors. Just to stay relaxed throughout this tough subject, we have to know that benign bone and soft tissue tumors are 100 times more common than malignant tumors. We classify bone tumor into benign and malignant bone tumor, and we subdivide them according to the predominant tissue. Benign bone tumor of bone forming is osteoma, osteoid osteoma, osteoblastoma, and malignant is osteosarcoma with its three subtypes: central, peripheral, and paraosteal. Benign cartilage forming tumor include chondroma, osteochondroma, chondroblastoma, and chondromyxoid fibroma. The malignant cartilage forming is chondrosarcoma. Benign fibrous tissue tumor is fibroma and fibromatosis. Malignant type of fibrous tissue is fibrosarcoma. Mixed benign tumor is chondromyxoid fibroma. Benign giant cell tumor include benign osteoclastoma, and the malignant is malignant osteoclastoma. The malignant type of the marrow is Ewing tumor and myeloma. Vascular tissue benign lesions include hemangioma, hemangiopericytoma, and hemangioendothelioma. The malignant type is malignant hemangiopericytoma. Other connective tissue benign lesions include fibroma, fibrous histiocytoma, and lipoma. The malignant connective tissue include fibrosarcoma, malignant fibrous histiocytoma, liposarcoma. Other tumors of benign origin include neurofibroma and neuroleiomyoma. The malignant type is adamantinoma and chordoma. The diagnosis and approach to tumor start from careful, detailed, and precise history and physical examination. Most benign tumors are asymptomatic, and they are found incidentally on the X-ray. Symptoms associated with the tumors include pain, lumpy swelling, local tenderness, constitutional symptoms, pathological fracture. And all the time, from the history, we have to exclude conditions that can mimic tumors. Most malignant tumors present with symptoms such as pain, localized tenderness, and constitutional symptoms. Moving after the history and physical examination, we order for the patient blood investigation, including CBC, CRP, ESR, and alkaline phosphatase with LDH. Regarding the imaging, tumors may be discovered accidentally during X-ray, especially benign tumor, or after pathological fracture. X-ray is the first imaging modality, and we must order a chest X-ray for the patient to rule out metastases. Size of the lesion may give a clue in the diagnosis. The site may be centric or eccentric. The site may be in the metaphyses, such as the lesion on this X-ray, or it may be a diaphyseal lesion, such in this X-ray, or epiphyseal lesion, such this one. So the site is metaphyseal, diaphyseal, and epiphyseal. Clue to the site is about the lesion, if it crosses the growth plate or no. In this lesion, the bone lesion, it crosses the growth plate. This lesion, the bone lesion, stops before crossing the growth plate. Another entity under the site description is whether the bone lesion arises from the surface of the bone, such as this lesion, or within the medullary cavity, such as in this lesion. Other description of the X-ray is the size of the lesion. Either it is 1/3, 1/2, 2/3, or the whole diameter of the bone, and whether it is multi or unilocular lesion, such as the one in this X-ray, or multilocular lesion, such the one in this X-ray. The third description is the zone of transition. I mean the boundary between the tumor and the surrounding bone. In well-defined narrow zone of transition, it usually suggests benign lesion. The lesion on the right side, it has well-defined narrow zone of transition with surrounding sclerosis, and this suggests a benign lesion. Usually ill-defined with wide zone of transition suggests malignant lesion. The fourth description is the matrix characteristic. Osteosarcomas produce bone and can be seen on X-ray as thin layers of bone extending out from the bone surface. Chondrosarcoma and Chondroblastoma produce cartilage and have a punched out or lytic appearance on X-ray associated with calcification. Fibrous tumors produce collagen, are often more benign, and appear as a bubbly lytic lesion on the X-ray. Ewing sarcoma is aggressive and rapidly produce undifferentiated tissue that attempt to ossify, and these tissue result in an onion skin appearance on the X-ray. Radiological findings that indicate benign bone tumor, well-defined, localized, with sclerotic margin, no cortical disruption or periosteal reaction. So when we describe this lesion, it is a metaphyseal lesion, it is an eccentric lesion, it is well-defined, localized, with surrounding sclerotic margin that indicate slow benign process. There is no cortical disruption or periosteal reaction, and there is no invasion to the surrounding tissue. So this is most likely benign lesion. Moving to the types of periosteal reaction in malignant bone tumor, We have two types, continuous periosteal reaction and interrupted periosteal reaction. The first type of the continuous periosteal reaction is the sunburst appearance. It is a divergent spicules that resemble a sunburst. The second type is the solid periosteal reaction, which is increased formation of a new bone, and usually it indicates slow tumor growth. Lamellated periosteal reaction, as the white above arrow shows, it may occur as a single or multiple layer, indicate a rapid tumor growth. Spiculated periosteal reaction, it is a spicule that indicate an aggressive tumor growth compared to the solid and lamellated types. So if we are going to describe the X-ray, it is an osteolytic lesion in the diaphysis, as the blue circle shows, with lamellated new bone formation, white arrow, and spicule sunburst appearance, as the red circle shows. The second type of periosteal reaction in malignant bone tumor is interrupted periosteal reaction. Codman triangle develops as a result of the destruction of a singular or multiple periosteal lamellae. CT scan is useful for assessing the extent of the tumor, the involvement of the surrounding tissue, and if there is cortex disruption or involvement of the articular structure. It is mainly for bone description. Also, another use of the CT scan is to rule out distant metastases. This is include chest, abdomen, and pelvis. Other imaging modality is the MRI. It gives us a better soft tissue view. MRI is used to know the extent of the tumor and the extent to the surrounding soft tissue. It will show also the medullary involvement and if there is cortical disruption or no. Other use of the MRI is to show the skip lesion. The skip lesion is another bone lesion in the same bone away from the first lesion. On image number 6 of the humerus, it is an osteosarcoma and it shows the skip lesion in the humerus. Radionuclide scanning. It shows non-specific reactive changes in the bone. This can be helpful in revealing the site of a small tumor, such as osteoid osteoma, or the presence of skip lesion, or silent secondary deposits. On this bone scan, it shows right femur lesion. This is an example of an osteosarcoma of the distal femur. The tumor is in the metaphysis of the distal femur. CT scan shows extracortical bony densities, which is characteristic of osteosarcoma. Radionuclide bone scanning shows increase uptake, and MRI shows that there is a lesion in the distal femur with extension to the surrounding structure. Biopsy, usually essential for diagnosis and planning of treatment. As little as possible tumor exposure, block of tissue is removed, ideally in the boundary of the tumor, because usually in aggressive rapid growing tumor, the central is necrotic. A frozen section should be examined, and this procedure should not ever be regarded as a minor procedure. The principle of incisional open bone biopsy is to use longitudinal incision in the extremities, which allows for extension of the incision for definitive future management, to be done by the surgeon who is going to do the future procedure, and do not expose the neurovascular structures. All the tissue exposed during the biopsy is considered contaminated with a tumor. We have to maintain meticulous hemostasis, and post-operative hematoma are considered contaminated with a tumor. We have to release tourniquet prior to wound closure, and biopsy should be performed through the involved compartment of the tumor. Closure, if we are using a drain, we have to bring the drain out of the skin in the line with the surgical incision. For rational treatment, we need to know the precise diagnosis, the extent of the lesion, the likelihood of distant spread, and the relationship to local blood vessels. Therefore, in all cases of suspected malignancy, investigation should include high-quality radiograph, CT, MRI, bone scan, and biopsy before definitive treatment starts. Principle of a treatment. For benign lesion, if the diagnosis is in doubt, we must do a biopsy to confirm the diagnosis. And if the diagnosis is confirmed, then we can treat benign lesion with follow-up or surgery, depend on the size and location of the lesion. Benign, symptomatic or enlarging tumor, I mean painful lesions and tumor that continue to enlarge after the end of normal bone growth, always require biopsy and confirmation of the diagnosis. If it is confirmed to be benign and we intend to do a surgical treatment, it will be complete local excision with or without fixation, depend on the site and the size of the lesion. In suspected malignant tumor, the patient is admitted for full assessment and to confirm the diagnosis, to establish the grade of malignancy, and to define the spread and metastases. Chemotherapy and radiotherapy is used with surgical procedure. Surgical procedure may be amputation or limb salvage procedure with wide excision or radical excision of the compartment. The prognosis depends on the overall stage of the disease, the presence of the metastasis, the skip lesions within the same bone, the histological grade, and tumor size. Enneking system is a malignant tumor classification. It is a surgical classification that predicts the outcome and the prognosis of the malignant tumors. It depends on the histological grade and whether the tumor is inside the compartment or extend outside the compartment. Stage 1A is low histological profile and intracompartmental. Stage 1B is low histological grade with extracompartmental extension. 2A is a high histological grade with intracompartmental, and 2B is a high histological grade with extracompartmental extension. 3A is any grade with regional or distal metastases, and the site is intracompartmental. 3B is any grade with regional or distal metastases with extracompartmental extension of the tumor. Keep in mind the differential diagnosis for any bony tumor: osteomyelitis, mainly chronic osteomyelitis, stress fracture, and gouty tophi. Moving to the metastatic bone disease, which is the secondary malignant tumor, it is the most common malignant bone tumor. It arises from the epithelial carcinoma of the thyroid, lung, breast, kidney, prostate, GI tract, and bladder. Most appears as osteolytic lesion on the X-ray, except for the prostate tumor, which appears osteosclerotic. In 10% of cases, there is no primary tumor found. The commonest sites for bone metastasis are the vertebrae, proximal femur, pelvis, the proximal half of the femur, and the humerus. Most common tumors metastasized to the bone are lung, breast, thyroid, renal tumor, and prostate. Bone resorption and osteolytic characteristic is due to direct action of the tumor cells or tumor-derived factor that stimulate the osteoclast. The commonest feature is pain. Other presentations include pathological fracture or incidental finding and symptoms of hypercalcemia. Picture A is for a patient presented with pain in the right thigh. The X-ray showed what appeared to be a single metastasis in the upper third of the femur. However, the radioisotope scan revealed many deposits in other parts of the skeleton. Patients over 60 years with vertebral completion fracture should always be investigated for metastatic bone disease and multiple myeloma. In picture D, it is a prophylactic nailing for a femur metastasis. Another X-ray that shows the osteolytic lesion and the metastatic bone lesion in the region of the proximal right hip. First, we will start with the benign bone tumor. We will start discussing non-ossifying fibroma or fibrous cortical defect. It is the commonest benign lesion of the bone. It is A developmental defect with nest of fibrous tissue appear within the bone and persist for years before ossifying. The clinical features: the patient will be asymptomatic and in almost always encounter as an incidental finding on the X-ray. The usual site are the metaphyses of the long bone. In the X-ray, the appearance is unmistakable. There is a more or less over radiolucent area in or adjacent to the cortex, so usually the lesion is eccentric on the X-ray. Although it looks cystic on the X-ray, it is solid lesion consisting of unremarkable fibrous tissue. And as the bone grows, it heals spontaneously. It may enlarge and cause pathological fracture. Treatment, except for pathological fracture, treatment is conservative and follow-up. This is an non-ossifying fibroma or fibrous cortical defect. The X-ray always shows a cortical defect, and in picture A, it is an eccentric lesion with surrounding sclerosis, thinning of the cortex, well-defined margin. In picture C, it is a pathological fracture through a fibrous cortical defect. Fibrous dysplasia. It is a developmental disorder with area of a trabecular bone which is replaced by fibrous tissue, osteoid and woven bone. The condition may affect one bone, monoostetic, one limb, monomilic, or many bones, polyostetic. The presentation is usually asymptomatic for small lesion. In big lesion, the patient may present with pain and or deformity or pathological fracture. X-rays show cyst-like area in the metaphysis or shaft, which have a hazy, the so-called ground glass appearance. The weight-bearing bones may be bent, and one of the classic features is the shepherd crook deformity of the proximal femur. Pathology: the histological picture is of a cellular fibrous tissue with patches of woven bone and scattered giant cells. This is an X-ray of fibrous dysplasia. In picture A, the large cyst-like lesion in the proximal femur has resulted in the so-called shepherd's crook deformity. In picture B, the X-ray show the typical ground glass appearance of fibrous dysplasia in the tibia. Usually, small lesion need no treatment. Large lesion, which has a big risk of pathological fracture, may be treated by curettage and grafting, but in fibrous dysplasia, there is high risk of recurrence. Osteoid osteoma. It is a benign tumor consisting of osteoid and newly formed bone. It is small, usually less than 1 centimeter, round or oval in shape, and surrounded by dense bone. Usually occur in patients under 30 years, and over one-half of the cases occur in the femur or the tibia. The clinical feature is characteristic. The leading symptom is pain, which is sometimes severe, and it is night pain awaken the patient and relieved by aspirin, not by rest. X-ray. The important feature is the tiny radiolucent area, which is called the nidus. The differential diagnosis is a small Brod's abscess, which may need biopsy to confirm the diagnosis. The treatment is complete removal of the nidus or radiofrequency ablation. This is an example of osteoid osteoma. The typical appearance is the nidus, which is the radiolucent area surrounded by the reactive bone thickening and dense sclerosis. The histology will show a sheet of pink staining osteoid in a fibrovascular stroma. Giant cells and osteoblasts are prominent. Chondroma or enchondroma. The tensional tissue is indistinguishable from the normal hyaline cartilage, but there is often a central area of degeneration and calcification. The clinical features of chondromas are usually asymptomatic and discovered incidentally on the X-ray or after a pathological fraction. This is a characteristic X-ray of enchondroma. The most common site usually is in the hand. We can see thinning of the cortex, well-defined lesion, and inside calcification. The appearance of enchondroma sometimes may mimic chondrosarcoma, and it is difficult to differentiate between them on the X-ray. If the diagnosis is in doubt, we have to do a biopsy to confirm the diagnosis. Here in the X-ray, we can see a heterogeneous bone lesion with calcification. Painful or enlarging, or if it presents as pathological fracture, enchondroma should be removed as thoroughly as possible with a curettage. Then the defect is filled by bone graft. There is a small risk of malignant transformation. We have to assess the patient regarding the onset of the pain, if there is any enlargement of the lesion or involvement of the cortex. Osteochondroma, cartilage-capped exostosis. There is a small risk of this lesion to develop a malignant transformation. The clinical feature of this lesion is a patient who is usually a teenage or young adult when the lump is first discovered. The exostosis may go on enlarging up to the end of the normal growth period for that bone, and any further enlargement after that is suggestive of malignant changes. The X-ray will show a defined bone protuberance exostosis arising from the surface of the bone, usually in the metaphyseal area. It looks smaller than it feels because the cartilage cap over the exostosis is not obvious on the X-ray. In large lesions which undergo cartilage degeneration and calcification, the X-ray will show the bony exostosis surrounding by area of calcific material, and here it is difficult to distinguish it from malignant transformation, and we have to do biopsy to confirm the diagnosis. For a young girl presented with a lump on her leg, it felt bony hard. On the X-ray examination showed the typical feature of a large cartilage cap exostosis. Of course, the cartilage cap does not show on the X-ray unless it is calcified. Histological section of an exostosis with its dark stained cartilage cap shown on picture C. Treatment. If the tumor causes symptom, it should be excised. If in an adult it has recently become bigger or painful, then operation is urgent, for these features suggest malignancy, even if the histology looks benign. Chondroblastoma. This rare tumor of immature cartilage cells is one of the very few lesions to appear primarily in the epiphysis, usually of the proximal humerus, femur, or tibia. Clinical feature: the presenting symptoms is aching and tenderness adjacent to the joint. The X-ray show the characteristic appearance of well-demarcated radiolucent area in the epiphysis of the bone. Treatment: in children, the risk of damage to the physis make it risky to remove the lesion. In adults, this is not a problem. However, there is a high risk of recurrence after incomplete removal, and if this happens repeatedly, there may be serious damage to the nearby joint. Simple bone cyst. This is a truly solitary or unicameral bone cyst. It appears during childhood, typically in the metaphysis of one of the long bones, and most commonly in the proximal humerus or femur. It is not a tumor and tends to heal spontaneously and is seldom seen in adults. Clinically, the condition is usually discovered after a pathological fracture or an incidental finding on the X-ray. The X-ray will show a large bubble inside the bone. It may occupy the entire metaphysis, but it does not extend beyond the physial plate. Asymptomatic lesion in older children can be left alone, but the patient should be cautioned to avoid injury which might cause fracture. Active cysts, those in young children, usually abutting against the physial plate and obviously allergic, in sequential X-ray should be treated. Aneurysmal bone cyst. This is a cystic tumor-like lesion. Occurs chiefly in the spine and metaphysis of long bones. It usually affects young adults and there is no risk of malignant transformation. It may expand and cause marked thinning of the cortex. Histological aspect: it contains clotted blood. In this X-ray, usually in a tubular bone, the cyst is always situated in the metaphysis and may resemble a simple cyst. Sometimes it is mistaken for giant cell tumor. The treatment of these cysts should be curated and bagged with bone graft. Giant cell tumor. Giant cell tumor is a lesion of uncertain origin that appears after the end of bone growth. It is aggressive lesion that is poorly defined and appear to extend into the surrounding bone. About 1/3 of these tumors remain truly benign, 1/3 become locally invasive, and 1/3 metastasize. The clinical feature: the patient is usually a young adult who complains of pain at the end of a long bone. Sometimes there is a slight swelling. Pathological fracture, occur in around 10 to 15% of the cases. Histological, the striking feature is an abundance of multinucleated giant cells as appear in this image, scattered on a background of stromal cell with little or no visible intercellular tissue. The X-ray show an epiphyseal lesion. So till now we have two tumors with epiphyseal location, Chondroblastoma and giant cell tumor. These lesions extend to the subchondral bone plate. The endosteal margin is clear cut, but in invasive lesion it is ill-defined. So in the picture on the left side, we show an osteolytic epiphyseal lesion with cortex thinning and well-defined margin. On the picture on the right, we saw an epiphyseal lesion with ill-defined pattern. Malignant tumors, they are either primary or secondary. Primary include osseous tumors such as Osteosarcoma, Chondrosarcoma, and the non-osseous include Ewing sarcoma, multiple myeloma, plasmacytoma, and non-Hodgkin lymphoma. The secondary malignant tumor is the metastatic bone disease, which is more common than the primary type. Osteosarcoma is a malignant tumor of bone where the tumor cells produce osteogenic matrix. It is the second most common malignant tumor of bone after multiple myeloma and the most common primary sarcoma of the bone. The peak incidence is in the second decade. It is either primary osteosarcoma or secondary osteosarcoma after budget disease of the bone, radiation, or bone infarction. It has a bimodal distribution. Primary osteosarcoma, usually in the adolescent age, and secondary osteosarcoma in advanced age. It is more common in male than in female. The site most commonly involved are the metaphyseal region of long tubular bones, especially the region around the knee in 50% of the time. Pain is usually the first symptoms. It is constant, worse at night, and gradually increase in severity. The patient also may present with a lump. Pathological fracture is rare here. Osteosarcoma usually metastasizes to the lung, skeletal system, regional lymph node. X-ray usually shows the sun-burst appearance and Codman triangle, a sign of osteolysis adjacent to osteosclerotic lesion. It is a heterogeneous lesion. The tumor margins are poorly defined, while the sunburst and the Codman are typical of osteosarcoma. They can also be seen in other rapidly growing tumors. This is example of osteosarcoma. This is the X-ray of the right knee. The triangular periosseal reaction Codman triangle is represented by the letter C. The new periosseal bone, which is grown in the surroundings of soft tissue is the spicular pattern, which is represented by the letter S. Both phenomena are general malignancy criteria of bone tumor and frequently occur in osteosarcoma and Ewing sarcoma. Another X-ray of the distal femur in a 17-year-old male patient. There is a sclerotic outgrowth of the bone surrounded by osteolytic destruction of the medulla and cortical bone. So it is a heterogeneous pattern of osteolytic and osteosclerotic region. It is visible on the metaphyses, mainly in the medial side of the femur. The periosteum over the lesion is non-continuous, indicating a rapid growth of the bone lesion. This appearance of mixed osteosclerotic and osteolytic lesion in the metaphyses of the long bone is characteristic of osteosarcoma. Investigations. Usually ESR is raised, also with raised serum alkaline phosphatase. X-ray, radioisotope scan can show skip lesion or metastasis. CT and MRI, chest X-ray is done routinely, and with pulmonary CT scan to rule out metastasis. The definitive diagnosis is by biopsy. Osteosarcoma tends to metastasize hematogenically and almost always starts with the lung. So, bone scan should be done because it expands intramedullary far from the primary lesion and will show skip lesion or metastasis. Treatment include chemotherapy, surgery, which I mean limb salvage surgery. Limb salvage is resecting the tumor and the bone with the surrounding soft tissue while leaving the bone end in place. Then we have to do reconstruction of the limb with a prosthesis and artificial joint or amputation. The prognosis depends mainly on the presence of metastases at presentation. Osteosarcoma in Paget's disease is very aggressive. The 2-year survival is unusual with any type of surgery. The second type of the osseous primary bone tumor is Chondrosarcoma. It arises from the mesenchymal cells that produce cartilage, arise in the medulla of the long tubular bone, mostly in the lower limb. The next most common site are the pelvis, central skeletal, and the ribs. Occur either as a primary tumor or a secondary changes in a pre-existing benign chondroma or osteochondroma. The X-ray on the left shows a heterogeneous lesion with calcification of the proximal humerus. The differential diagnosis is enchondroma or chondrosarcoma. The CT scan showed the calcification with industrial thinning of the cortical bone. The final diagnosis was after biopsy is a low-grade chondrosarcoma. The image on the right shows the industrial scalloping at the medial side, which is a hallmark of chondrosarcoma. This is an example of chondrosarcoma arising from osteochondroma, and measuring the cartilage cap will help in distinguishing between osteochondroma from chondrosarcoma. Within 2 cm used as a cut-off for distinguishing benign osteochondroma from chondrosarcoma. Another example of a primary chondrosarcoma that appears as a large lucent area, heterogeneous, expanding to the cortex. A characteristic feature is the patchy calcification in the center of the lesion. It is well demonstrated in this case. Note that the lateral aspect of the cortex has been fractured. Treatment: complete surgical excision, as this tumor does not respond to chemotherapy. Recurrence rate is high. The prognosis is related to the grade of the tumor. Low grade, better prognosis, and the ability to completely surgically remove the lesion. Ewing's sarcoma. Ewing's sarcoma is believed to arise from the endothelial cells in the bone marrow. The peak age is 10 to 15 years old. The primary tumor usually often in the diaphysis of the long bone, particularly femur, tibia, fibula, and humerus, and the bones of the pelvis. Usually, it is associated with metastases to the lung, skeletal system, and bone marrow. The patient presents with pain, often throbbing in character, and swelling, generalized illness, and pyrexia together with a warm, tender swelling and a raised ESR may suggest a diagnosis of osteomyelitis, and sometimes it's very difficult from the histophysical examination to differentiate between Ewing sarcoma and osteomyelitis. This is an example of Ewing tumor, the bone destruction in the mid-diaphysis and the soft tissue swelling. The sun ray appearance and the Codman triangle are usually associated with osteosarcoma, but they are just as common in Ewing sarcoma. In this example, the new bone formation may extend along the shaft of the long bone. This is another example of Ewing sarcoma. The X-ray show lateral view of child's knee and lower leg. There is zone of decreased radio density in the proximal tibia diaphysis, with lamellated periosteal reaction producing a typical onion skin appearance of Ewing sarcoma. Diagnosis is very important to get biopsy, and the prognosis is always poor, and surgery alone does little to improve it. Treatment is a combination of chemotherapy, surgery, then radiotherapy. So to summarize things up, Ewing sarcoma, the age group is usually children and adolescents. The main location is diaphysis of long bone. Radiologic characteristic is onion skin appearance. Treatment, surgery, polychemotherapy, and radiation. The 5-year survival is around 70%. Osteosarcoma, the age group is usually adolescents and young adults. The main location is in the metaphysis of the long bone. On the X-ray, we will see sunburst appearance, Codman triangle, and moth-eaten appearance. Treatment is surgery and polychemotherapy. The survival rate is around 70%. Chondrosarcoma, usually age group is adults. The main location is in the pelvis, ribs, proximal femur, and proximal humerus. On the X-ray, we see the moth-eating appearance, the endosteal scalloping, and intralesional calcification. Treatment is surgery. The 5-year survival is from 50 to 60%. Multiple myeloma. Multiple myeloma is one of the commonest causes of osteoporosis and vertebral compression fracture in men over 45-year-old. It is a malignant B-cell lymphoproliferative disorder of bone marrow with a plasma cell predominating. Results in bone marrow cell proliferation and increased osteoclastic activity, which lead to osteoporosis and lytic lesions throughout the skeleton. Late secondary features are due to renal dysfunction and spinal cord or root compression caused by vertebral collapse. This is example of multiple punched out lesion of the skull and the femur, characteristic for multiple myeloma. Differential diagnosis is secondary malignant metastatic bone disease. Investigations: there is anemia, high ESR, predicted Benz-Jones protein in the urine, abnormal band in the electrophoresis, increased creatinine and calcium, plasmacytosis with typical myeloma cell in bone marrow puncture. Most common immunoglobulin in multiple myeloma is the IgG. Treatment: we start consulting hematologist, immediate correction of spinal fracture, alkylating cytotoxic agent, corticosteroid, and radiotherapy for solitary plasmacytoma. And thank you for listening to my lecture.